loosen up.
Oh, I'm wearing my new pajamas. I had to get them.
Loosen up. Yeah, I got my nice little headband on from Willy Bands. Wiley, I don't know if it's Willy or Wiley, but the collection is growing. I've got 2 more in the mail. They're out of
Nice.
Bettendorf, not sponsored.
Oh,
But I love these, and they're the kind that you like tie yourself. So
nice.
I'm in love with them. And I saw another nurse, a float nurse
That's
came
super
up.
cute.
Yeah, and all sorts of crazy patterns, but another nurse came up and she had on a pattern that I had recognized from the website. And I was like, oh my God, you've got Willy Bands. And she was like, yes. And I ended up giving her a report. So we kind of bonded over our headbands.
Bonded.
Yeah,
Nice.
not sponsored.
I colored my hair.
Oh, it's beautiful. It has like kind of like an auburn, like purpley reddish.
It's supposed to be blue.
Oh, well.
But the blue didn't really come through, so it looks more purple.
It's the lighting. It does have like a purplish hue. I want to see it in person. I'm sorry I didn't recognize the color right away.
Oh, no.
How terrible of me.
Oh, that's all right. Because we're on a camera on Zoom and my hair's pulled back.
I'm rocking the top knot that I've complained about in previous episodes.
I like the top knot.
Thanks.
It's good.
Welcome to Nursing Uncensored. Here we are. It's me and Mackenzie back today. Mackenzie is my friend. She is a staff nurse, faculty, clinical staff, a SANE nurse, and just a mom and a wonderful person. So welcome back, Mackenzie.
I'm so glad to be back.
Yeah, we did our previous show about sexual assault nurse examiner training, and today we're going to lighten up a little bit and talk about some of our, I was about to say our favorite pet peeves, but we don't have favorite pet peeves. We're just going to talk about some pet peeves, some stuff that's been bugging us as of late. And everybody loves the pet peeve episodes because everybody can get down with that. Everybody's got shit that bugs them.
Well, the funny thing is it kind of carries over. Like every nurse has experienced all of these things.
Yeah, absolutely. I think there are some universal truths to nursing, and I think that that's where a lot of the like nursing humor comes from. Like we all find ourselves in these situations that are kind of ridiculous, gross, abnormal, stuff that like most quote unquote like normal people don't go through or don't like get the joy of experiencing ever, if not on a regular basis. Like whose lives are like this besides like nurses, CNAs, and our other like friends in the medical field.
For sure.
So,
it
no, you go ahead.
I was gonna say it always reminds me of like when my toddler's throwing this huge tantrum. Like I'll have other parents come up and like, I got you. Whenever I see another parent like having a tantruming kid, I was like, the struggle is real. Nurses are like the same thing. It's like we all get it. You can tell another nurse like I had a shitty day, and they would like, yeah, I've been there too.
And we even like on our units, especially when you're with a team of nurses that maybe you work really well with or that you've worked with for a while, and you kind of got to have each other's backs. Like the last shift that I worked just a couple nights ago, I had a couple patients that were really trying my patience. Like they were getting on my nerves. They were really difficult. They were angry, screaming at me, not being so nice. And my coworkers stepped up. They were going in, I'd go in to put their oxygen back on and I'd get yelled at, and I was called the oxygen police and just, stuff. I'm like, I'm trying to save your life, bro. Like trying to keep you breathing. Sorry, I'm barging into your room in the middle of the night, but your oxygen's at 68%. Just thought it'd help you out. Bah, get out of my room. So yeah, I got that. But my coworkers were like, you know what? This time I'll go in. You go chill out for a minute. Uh-oh, the earth is falling down. Your earth.
Sorry.
No, you're
like
good.
Adjusting
you're good.
my phone.
But yeah, so we gotta tag team these like in and out, make sure that we're like watching each other's backs. Because sometimes the irritation is real.
Can I don't know if I should admit this.
Uh-oh.
When I worked up back on, I know this is probably a pet peeve that someone would have. When I worked on burn, we had a patient who was delirious. And so he just kept on yelling out, nurse, nurse, constantly and requiring something. So I let him know what his nurse's name was. And so he remembered it.
That nurse probably hated you. Was it your friend?
Sherry! Huh?
Was it your friend that you did that to?
I was like, yeah.
We'll keep going.
We were court. Yeah. My phone cut out. I was saying yes. Yeah, but it just always left.
That feels like something I would do to Brad. Brad doesn't listen to these episodes, so I can say that about him. Oh man. Yeah, we have patients that we had a patient that would remember our names and would shout out our names, but it was he'd just read our badges. It wasn't like you'd have to tell him your names. He just knew who you were. So he'd shout out your name. There sometimes though it's funny, sometimes it's funny and cute when your patients remember your name or they like call you a name that's not your name. But sometimes that's like listening to somebody scream your name for 12 hours. Oh, that's enough to drive you up a fucking wall. There was, I don't know if I've told this story on the show before, but there was a patient that we had that was like right by the nurses station. So actually there's two different stories, but it's basically the same story, just two different patients. There was a patient while I was on the unit I'm on now that was right across from the nurses station, and he liked to watch videos on his computer, and he'd watch like YouTube videos all the time, and he would watch Supermarket Sweep, and it was just like constant Supermarket Sweep videos over and over again.
I know who you're talking about.
Volume up, Supermarket Sweep all night long. So it just got to a point where like now I'm like, if I heard like Supermarket Sweep videos, I'd like maybe twitch a little bit. There was another patient on a different unit years and years before. It was when I was working on neurosurge, and the patient was watching TV and like fell asleep with like TV Land on or something like that. And it was an Andy Griffith marathon. So like every 28 to 30 minutes, you'd hear that fucking whistle intro of the show. Yeah. Every fucking 28 minutes for 12 hours, you're listening to that fucking whistle intro, and the patient's hard of hearing, so they got that shit cranked. I swear I thought I was going to lose my mind. And if you go in and turn it off, the patient wakes up and they're like, why did you turn off my TV? And so you're like, oh shit. So you can't poke the bear. You can't go in and just turn that shit down, because then they wake up and like asking you for shit, and they want to be moved every 5 seconds. So you got to just deal with the Andy Griffith every 28 minutes. Yeah, that's just how it goes. Yeah, sometimes there are interesting sounds, or this sometimes is cute, but this is also a pet peeve when you have like one patient that just like, is confused, yelling all night, and the patient in the next room is also confused and is responding to them. Have you ever had that? Or like the patient is like,
you know what I've heard, because I haven't worked overnights for so long.
Oh yeah, you don't get the sundowners. You don't get the pleasure.
I don't get the sundowners.
So like when the person in 19 is like, help, I need my shoes. And the person in 20 is like, what do they look like? I'll help you find them. And you're like, oh God, you're sitting at the nurse's station and you're like, maybe we should just put them in a room together and they can just like entertain each other for a while. Like, or you got the two little old ladies that are just calling out. They're confused and they're like, like I was trying to find a spot to draw blood on a patient the other night. And she was, pleasantly confused. She wasn't like angry or anything. But like as I'm trying to feel for a vein, she's like, did they bring that camping equipment down here yet? I was trying to get the tent set up, and you're like palpating, trying to keep her still enough that you can like palpate for a vein. And she's like, I told Rudy to put the tent down over there. And you're like, just hold still, ma'am. It's okay. Yeah, he brought it down. He put it down by the lake. And oh no. You're having these like imaginary conversations with people, and you're just like, God, this is my life. This is like real life for me. I'm having like imaginary conversations about camping equipment that doesn't exist. Are these pet peeves, or are these just like alternate realities that we live in? Is this just like stuff that we deal with that most people don't realize?
I think it's just like stuff you deal with. Sometimes, so because what I was thinking too, when you were saying like patients talking to each other, was we have VMU, so the video monitoring it, and when they talk out of the camera, I've had delirious patients like, who was that? Like, and try to like figure out who they're talking to and like respond.
So for people that don't know, when we have patients that need like one-to-one care, or like maybe they're a fall risk but they redirect easily, we have these like towers on wheels. There's like a camera on it and a like a speaker or microphone situation, and then we have nursing assistants sitting in this little room somewhere with like a little screen with all these cameras on it, and they're watching patients on like closed circuit TV, so that way if like the patient's about to get out of bed or rip out an IV or rip out a feeding tube or something, they can send off an alarm depending on how emergent it is, and then the nurse can go run in there and stop disaster from occurring. But it's funny because then when you talk to the patient, you like push a button and it's like a robotic voice that is like, do not do that. And sometimes the patient is looking around like, Lord, is that you? Or like, yeah. And some patients get to know that they're in trouble when they hear that voice. I'll be like, all right, I'm done. Okay, sorry.
For sure.
Or the little old men that'll be like, they'll be like, oh shit, I set that thing off again. It's great when they start getting frustrated by it. They'll be like, damn it, I'm fine. I'm not going anywhere. As they're like getting out of bed. I'm fine. Talking to like this pole in the corner.
Sure. Oh, it's only funny because it's so true.
Yeah. One of the pet peeves that I wrote down, which I know other nurses have had this experience. So when people come into the hospital, some people, they're on like a million medications, and instead of, having a list of the medications they're on, they'll just like bring in all the medications. And sometimes, I know I try to cut people slack. I know it's hard to keep track of all this, all these bottles of stuff. But sometimes they'll come in and they'll have like a grocery bag or a Rubbermaid container or something, and it just has tons of pills in it. And as nurses, we need to go through this stuff. And if it's just like, random stuff, there's no controlled substances, sometimes we'll just like put it in the medication room with their name on it so that when they leave, they can give it back to, because we don't want them double dipping. We don't want them taking these medications while we're giving them medications, and we need to know what they're taking. But then, you go through their meds and they've brought in all their controlled substances. So they got like 150 Xanax in a bottle. And first of all, you're like, what the fuck are you doing with 150 Xanax? Like, why do you have this many why do you have this many? And then second, you're like, I gotta get security up here. We gotta count all this shit. We gotta know exactly how many there are. Or they bring them in and there's 150 of them, but they're like all cut in half. And then the security guard comes
one time
up.
I had a patient.
You have to apologize to them before they start counting.
No, I'm so sorry. I had a patient once who he was really like a poor historian. He wasn't quite sure on what medications he was taking, and he did that. He just brought this huge bag filled with pills, and so I had to go through them, and all the pills were mixed together. So like one bottle had like 5 different kinds of pills in it.
No.
And I had to see if any of them were like controlled substances. So I had to like, go through all of these pills. He like brought all these pills that he wasn't supposed to be taking. I mean, it was just like a mess. It took me so long to go through all
There were
those
like
freaking
some
pills.
Skittles in there. Like,
Yeah. I was like,
no.
what is this white pill? Oh, that's a chiclet.
No, it makes
Oh,
you want,
it took
like,
so
that's so
long.
dangerous. That's like,
Right?
God. I mean,
Mm-hmm.
I know it's difficult, for I have a hard time talking about these things without like wanting to give 100 disclaimers of like, I know it's complicated. I know that it's difficult. I know there's a lot of stuff to go through. But also I'm like, how are all these people not dead? How did you not like mix
I
up your
know.
benzos with your aspirin and your yeah. Or like I had a patient once that
Well, and it's
kept asking me for more Xanax to help her sleep. And, I was like, I can't give you any more. What else can we do? What else would you do if you were at home and you couldn't sleep? Well, I'd just take another Xanax. And I was thinking, like, my God, woman, how many Xanax do you take at night? Do you just take one every time you wake up? Like, what the fuck?
Mhm.
So that's a good time for education.
Yeah,
That's a good time to educate your patient
it
on
is.
PPD.
Yeah. Well, because it's never people who have like, just omeprazole and a laxative, right? Like something
Mm-mm.
simple. It's always patients who have like, you know, 10 different cardiac meds
Mhm.
and, like
Pain meds
everything for
and
CHF, like
yeah,
pain
and
meds
then
and
sleep aids, they take like 3
yeah.
different things, plus they take Ambien and, you know, and then, I take, an over-the-counter sleep aid and I feel fucked up for 2 days, so there's that, but who's who's judging, right? Who's judging?
I can take a lot of like my insomnia has been horrible through COVID. And so I take trazodone and I just keep up. Like I'm kind of like your patient. Like, what do you do when you wake up? I just take another trazodone. Like,
I
I
mean,
don't.
everybody's different. I have disordered sleeping. I
Yeah.
probably should be on some kind of sleep aid so that I could sleep normally. It's like 9 o'clock at night now. I've been awake since 4:30 this morning, and before that I slept
Oh,
for like 19 hours. I got off work Sunday morning and then I slept till Monday morning. So go me.
are you just trying to?
I don't know what I'm no, yeah,
Do you
no, I
flip?
don't know what I'm doing.
Yeah.
There's no intention behind any of this.
Uh-huh.
It's just a free for all right now. I'm off till
Yeah.
Friday, so who
That's so
knows?
nice.
It is so I had to take a furlough day this week. And I'm really
Uh,
glad because the last couple shifts I worked kind of knocked me on my ass, which is why I was like, yeah, let's do a pet peeve day. I got loads of pet peeves. I got loads of pet peeves.
anyone who's willing to listen to me bitch about like
Yeah.
things,
Like
I'm so happy to share it.
yeah. Another pet peeve that I have is okay, so we on my unit, we don't have like a licensed, like we don't have somebody on our unit that can write orders for us if we need orders. And so sometimes we have patients that, patients on my unit, as you know, like they can get kind of critical, but most of the time they're on the edge of critical, but they're not really critical. Like they might have soft blood pressures, but really they're fine because they've had soft blood pressures. We're not going to do anything about it. Or they've had some AFib, but we know about it. They're anticoagulated. We're not going to, their heart rate's been a little fast, but they've been kind of tacky and they're, asymptomatic. It's probably fine. But this shit starts to happen at like 10, 11, midnight. And the doctor that's on call is the doctor that's crabby as fuck and doesn't want to be bothered for shit that's not super important. And you're like, well, these numbers are borderline. And I could just text them and be like, just so you know, just so that they're aware, so that if something goes weird at like 3, 4 in the morning, I'm not waking them up to some new information. But it could be nothing. So maybe I could just avoid paging them. And then you have this conundrum of like, do I piss off a cranky doctor over nothing? Or do I say nothing and then maybe this turns into something and they'll be like, why didn't you fucking tell? It's like this dance of like, this isn't really important, but the orders say I'm supposed to call, but really is not that big a deal. And yeah, has got a fever of 100.8, but really he did the other day too. And I could just give him some Tylenol and the world goes on. You know what I mean? Like when you're
Yeah.
right on that razor's edge and you're like, it's probably fine.
See, it's weird because our unit works, we don't have residents, right? So we
Right.
only have,
Like
our
you're calling your
attendings.
staff
You're
doctor at
calling your staff
home.
doctor. And so and they're always way more crabby. When it was a resident, when I worked, trauma, and like I didn't care. I was that nurse. I hate alarms. I like noise fatigue is
Mm,
for sure a thing. And I
God,
hate
yeah.
alarms. And so, those alarms that just keep going off, like they're an AFib. We know they're an AFib. We're not doing anything about it. They're already like, on a
I
beta
don't
blocker.
want a
And
regular heart alarm.
yes. And
Turn
so,
it
you know,
off.
yeah, before we could even make adjustments, the 10%, I would call my docs, like, especially burn with everyone's heart rates were always really high, so we go
Mhm.
and like call them like, yeah, why are you calling me? And I'm like, because that's your call force. If you don't like it, change your orders. Because
Mhm.
if I have to listen to this, you have to listen to it. Like I cannot, like
Mhm.
I am not letting you get off the hook. I hate this. And if you hate me calling you, then change your orders.
Yeah. Yeah.
It
But
drives me
like
nuts.
but it's really hard now to do that because you're not calling someone who's on call in the next building. You're waking someone up who is a staff physician that has to be there at 9 o'clock the next morning to be there all day. And they're gonna probably yell at you for waking them up over something that they don't give a shit about right now. And they don't give a shit that you give a shit about it right now. And that's not to say that we don't have great physicians. They do wonderful things. I'm not going to justify that one in one direction or the other. But yeah, it's like sometimes when you don't have someone that's right there that can write orders for you, um, it becomes a dilemma of, and that's where the autonomy comes in. Is this something that can wait till morning?
Mhm.
And if so, how do you explain to your patient that the thing that is bugging the shit out of them, the only thing they can think about at 2 o'clock in the morning is not important enough to wake up somebody who's going to yell at you? And how do you tell your patient that no, that colace that's not going to kick in immediately can wait 4 more hours so that you don't get chewed the fuck out over the telephone? Yeah,
Yeah.
it's those decisions.
Yeah.
It's that shit that drives me crazy when you're like, no, I am not calling about this. And to that same, this is also a night shift thing and not having a resident on the unit. When you like draw labs and you draw labs just early enough that you get a critical result before the day shift doctors are in, but night shift is on their way out and they're not going to give a shit about your low sodium or your high
Mhm.
potassium. And they're going to be like, tell the day shift. But you know that you don't see the day shift until you're like walking out to the car. So you have to explain to the tenured day shift nurse you're giving report to why you did nothing about that high potassium result that you just got back. So
Yeah.
yeah.
I Yeah, that was the nice thing about, to a degree, when we had pagers, right? Because you could just send the message,
Right.
and if you didn't need a response back, you at least did your due diligence of
Yeah,
informing them.
but if it's a physician, we have some physicians that don't have pagers. You have to physically talk to them.
Right,
And so if you want to
right.
send just a quick little FYI, you don't get to do that. You have to, hello, this is Adrianne. I'm
Yeah.
calling you about Mr. Blah, 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 about blah, blah, blah.
Hmm.
And
Yeah.
sometimes,
I don't
yeah,
miss.
I like
Yeah, I don't
technology.
miss
I
having to do.
really, really like technology. I like being able to send a text page, you know.
Mhm.
FYI, patient's heart rate is blah, 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 asymptomatic, all other vitals stable. There's my name. There you go. You've been
Yep,
notified. If you
yep,
want to call me back, you
yep,
can. If not, yeah, huge pet peeve. Huge.
yep, yeah. We could probably tag on to that. My other pet peeve that I talked about
Yeah,
is like stroking
tack it on.
egos.
Tack it on. Tack it on.
That's the other thing. Like, I hate trying to make a doctor think it's their idea, or an LIP. I'll just say LIP,
Hmm.
to make it think it's their idea in order to get what you know your patient needs.
Hmm.
Right? Like, it would just be so much easier if I could just say, hey, the patient needs this. And they would be like, okay, I'll put an order in. Versus, if they didn't think
This
about it, they
this
didn't
like
say it.
old notion of instead of being like, "Hey doctor, I have a patient that looks like this. I think the patient needs this medication at this dosage, this interval." And then the doctor being like, "No." You know,
Yeah.
they tell you like, "Well, make them think it's their idea." Be like, "So, doctor, do you think this patient would benefit from this medication?" Um,
Uh-huh.
yeah.
What are your thoughts about? Yeah,
Yeah.
I had a patient once who we just got him off of pressors. Like, he had been on pressors for days, super sick. And we finally got him off of pressors, and the attending was like, pull all the lines. I'm like, are you
No.
are you sure? Like, are you sure? Are
That's
you,
real
are
fast.
you like, yeah, like, I mean, he hasn't even been off of a pressor for like 20 minutes. Like, don't you want to see how things go just in case? Because he's failed every other time. I'm like, it's an infection risk. Get him out. And I'm like, oh, okay. Like,
Infection
you
crash.
know, I
Which one comes
yeah,
which one's gonna happen
like
faster?
perfume, keep a heart pumping versus yeah. It was just like, so especially with that doctor just making him think every time. It was like, what are your thoughts about this? Or like, what do you think about, like everything, just so he like,
Yeah.
yeah, that's a great idea. I think that's a wonderful idea.
No, and
Yeah. I
I have been lucky enough that so I have had that experience where I feel like I've had to kind of like dance around and be like, look at this good idea that you could pick up off the ground right now. But then I've also had doctors, especially on the palliative side of things, you know, because a lot of our physicians, you know, they're in the business of saving lives and maybe they're not as well versed with orders for end of life and how to treat, you know, terminal agitation and that sort of thing. And so I've had doctors say to me, what do you want? What do you think? And not like, what do you want? But like,
Mhm.
what do you think is best? Like, what orders do you
Yep.
want? Is there an order set? Like, what's your expertise on this? All of those phrases have been said to me. And in that case, you know, if I don't know, I'll say, I don't know. Let me ask one of my more experienced colleagues, or I'll say, hey, there's an order set. Maybe you could start from there and I'll see, you know, or I've
Mhm.
seen this dosage with patients with similar diagnoses. And then we can kind of come to a consensus together. But those are the physicians that I
Yeah.
respect because they're not just like, oh, lowly nurse, I will decide, you know. I like when we can
Yeah.
collaborate
Oh
on
yeah.
this. But yeah,
Hmm. Yeah.
I've
I
had
would
some
say like,
doctors that or and not just doctors, like we're talking providers across the
providers, right?
spectrum. Yeah.
Yeah. I would say more often than not, providers are willing to work with you, like,
Yeah.
are wanting to do teamwork. Every once in a while though, you just get that like one shitty provider that doesn't want to, like,
Yeah.
oh, there was one time it made me so mad. I had a patient who was in palliative end of life, and when I came in, we're doing tons of stuff like OptiFlow and infusions and boluses and all of this stuff. And she was already having a hard time breathing. And I was like, what are we doing? Actually, she wasn't my patient, it was one of my students' patients. And I was like, this doesn't make any sense. Like, if we're going comfort, like, none of this is comfort. And so I just went in to tell the provider, like, I said, I'm going to just contact the primary team so we can get some of this changed. They're like, well, maybe not. And I'm like, why? And they are like, well, they just have a hard time kind of like giving up some things. And so we're just kind of like easing our time into like getting the doctors comfortable.
No, please
And
don't let the
getting the doctor not the family.
while the patient.
Yeah.
Yeah, while the patient is
Yes.
like being
And
filled up
so
with fluids and
yeah, so I think my student was with me, so not many students could actually see me full force advocating. Like when you get that like mama bear kind of like, what the
like,
fuck are you
no,
doing?
no.
And I was like, no, yeah. I was like, wait. I stopped her. I was like, wait, I just want to clarify if I'm hearing you correctly. You don't want me to contact the team to change orders for my patient for what's best for my patient and what they want because we're worried about hurting some egos. And the med student was like, yeah, and the fellow shrugged his shoulders. I was like, yeah, you can do that. I'm not like, that's not acceptable to me. My job is not to make sure someone's ego feels good. My job is to make sure my patients get the best care that they need, and that they want and deserve. Right. So yeah, it's always been one of my huge pet peeves. Like, let's not play a game. Let's just like, we have the same goal to get the patient feeling better. Like, or, yeah, I mean, pretty much feeling better, right? Whether that be comfortable or curing them or, like we want them to feel better.
Right.
Whatever that may look like.
Right. Yeah.
So,
and
yeah.
it's scary to speak up those first few times, but once you see that it actually makes a difference, and whether or not your patient can thank you or recognize what you did for them, you know what you did for them and you know what difference it makes. So it gets easier over time. It's hard. The first time I spoke up, it was really scary, but I once got a patient that didn't qualified for hospice simply because I noticed that he had a massive weight change. He didn't qualify. And I was looking through the hospice qualifications list. And one of the things that qualified was like, I can't remember, it was like a 30-pound weight difference in a particular number of months. And I was like, whoa, whoa, whoa. One of the things that he was admitted for was like a massive weight loss, and they reviewed and they were like, oh, we didn't see that he had a more recent weight put in, and the man qualified for hospice. And that was like early on, that was like really early in my career as a nurse.
Yeah.
And this guy was like, I mean, his health was changing rapidly and he needed home care. And so that was one of those things that I was like, had I not been just digging around being like, why doesn't he qualify? He's had all this shit happening to him. Why doesn't he meet these guidelines? And then I was like, oh, somebody forgot to like type his weight in this box to trigger this fucking whatever. It doesn't even have to be you going toe to toe with a provider. It can be as simple as like, oh, nobody typed this information into the right place, and paying attention
Right.
and like looking over. But yeah, it's that's a pet peeve of mine too, is when people just like, they're like, oh, okay, then we're not gonna do that. Okay, all right, that's it. Just look a little harder.
Is
Just
that
look a little
tunnel
bit
vision
harder.
too?
Yeah.
I know.
Yeah.
I know. Yeah.
Yeah. Imagine
Yeah.
the things we could do.
Oh man. Well, because I corrected a resident once. She did not realize that I was a nurse for her patient. She thought I was endocrine, apparently. And I was calling her and asked, because I had a patient who was on, insulin drip, but we were over our algorithms. So we were in ICU algorithms. And we weren't making any, or she needed ICU algorithms rather, because we weren't making any headway. Right. I was like, she needs more insulin. Like, I can't do anything with this. And so she's talking, she's like, I think it's endocrine. It was like an R1, like July. And I was like, no, 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 no. I'm the staff nurse caring for your patient. And she goes, oh, it's just the nurse. And I was like, oh. When she came up to the floor, I was very nice about it because I knew she was brand new, and like young. And I was like, hey, so you might want to be careful of like who you say that to because um, like just a nurse is like a cuss word, right? Because we're smart. Like you don't get into nursing because you're not smart. Like we're smart. We're with the patients all the time. We see all these changes, as long as you don't get tunnel vision, because that's my other, like that could totally lead us into one of my other big, huge pet peeves. But like just stepping back and looking at big picture versus like I have this set of orders, I have this set of meds that I have to give, like I just need to do these tasks. Nursing's not like that. I tell my students all the time, I could train a monkey to put in an IV in someone, right? Skills aren't what makes a nurse. Critical thinking is what makes a good nurse. Like, absolutely. And if you get tunnel vision to say, I have this list of things I'm supposed to do. I mean, yes, we have a shit ton of list of things we need to do, but
that's when you start focused on that, you're to shitting patients.
Yeah. Yes. Yeah. And there's that segue. Yeah.
Yeah.
Oh, it drives me bonkers. I remember coming, oh, I hate it. I came in a day shift and, it's stressful on the floor right now. Like people are just kind of like, or it was, it feels like maybe it's getting a little bit better, but it was this is like, like the midst of the worst of COVID and everyone was just like, to the max. But she proceeds to tell me that my patient's been shitting all night. She goes, but I gave her Miralax and Arsena earlier. And I was like, why? What? I think I said why 3 times. Like, why did you give laxatives if she's been shitting? And she goes, well, she's on a lot of narcotics. I'm like, yes, she is. But she's had diarrhea for like 3 months. And obviously those narcotics are not binding her up because she's shitting all the time. Like, and she's like, well, the other night. And I love this nurse. Like, I don't want to, but she goes, well, the other night she only had 3 bowel movements. And I was like, what the fuck? Who has 3 bowel movements in one night?
How many did you have last night? Like,
I
you want to say to people, like, what's normal for you? Do you have 3, 4, 5? Like,
man, if I have 3 bowel movements in a week, sometimes I'm like, hallelujah. Like,
or, the other thing is with lactulose. We give patients lactulose and usually the order says titrate to like 3 to 4 bowel movements. Well, I've seen and heard situations where like the nurse is giving a report and she'll be like, yeah, he pooped like 9 times last night. Did you give the lactulose? Oh yeah. Oh, after how many bowel movements? Oh, after like, he'd had like 4 or 5. Oh, did you read the order? Oh, no, I missed that part of the order. It's like, dude, you didn't have to give him that lactulose. The poor man's been up for the last 18 hours, shitting his fucking brains out.
I know.
Like, no.
Like, anyone who's on enteral feeds too, enteral feeds and no narcotics. We should just take away the laxatives. Yeah. They're not going to need them. Yeah. Those enteral feedings are going to make anyone shit up a storm.
Yeah. I think that patients need to be asked about that because I was telling you a story before we started recording. I had a patient that I was giving medications to, and normally with my patients, I go over the medications. Like, even if they know their medications really well, I still tell them what I'm giving them. Here's your Prilosec, your metoprolol, blah, 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 blah. I tell them what I'm giving them. Well, in this case, I was going through meds with a patient who I had taken care of a number of times before, All the meds were the same. But the nurse had already told me that he had had several bowel movements, didn't want his stool softeners. So I left those out. I didn't even take them in the room. So I gave him his meds. All of it was really benign. There were no narcotics, no controlled substances of any kind. It was just like some GERD meds and like, nothing earth shattering. Gave him the meds, he throws them back, and then immediately after taking them, he gets this look of like terror on his face. And he looks at me and he goes, "Oh no, I should have talked to you before I took those." And immediately, like, my blood runs cold and I'm like terrified. Oh my God, what did I give? Even though, like, I knew I didn't give him anything that's going to harm, like, there's nothing that's going to harm him in any way. But yeah, he's like, "Oh, did you give me poop meds?" And that's what everybody calls them. Nobody's like, "Did you give me Senna and Colace?" Yeah, everybody's like, "Did you give me
Right.
poop meds?" And I'm like, "Oh no, no, day shift nurse told me that you didn't need them. I left them out." The relief on his face, but the terror that struck in me, the way he looked at me thinking that he was going to be up pooping all night was true and real. I mean, you would have thought that I had given the guy fucking cyanide or something, because just
No.
the
I,
terror.
I feel so bad for the patients where they're like, they have, they're incontinent because they have diarrhea, and they're like, "I don't know what's wrong with me. I never do this. Like, I'm so sorry." And it's like, no, it's okay. We're like giving you a whole bunch of meds that not like mess with your body. And we're probably giving you meds to do this to you. Like,
Yeah.
um,
That's when I
they're
pull out the line, hey, I say to people, "Hey, have you ever heard the commercial, what happens in Vegas stays in Vegas?" Hospitals just like that. And usually people laugh at that. Um, and then my more tender, gentle line that I use, which I have things that I say. These are not insincere lines. These are just kind of things that I have on hand.
yeah.
Um, but if, sometimes you have these little old ladies that are like, "Oh, I'm so ashamed. I'm so sorry you have to do this for me." And I usually say to them, "I hope someday somebody has the kindness of heart to do this for me." And
Mhm.
then they usually say, "Oh, okay." Or the other thing that I'll say to people, especially women, sometimes men will respond to this as well, but especially old women, I'll say, "Do you have any children?" And most of them will say yes, or yes, I did, or "Oh, I helped raise my sister's kids," or whatever. Most
Mhm.
women have had kids in their life at some point. And I'll say to them, "Well, you've been taking care of everybody else your whole life. Now is the opportunity for you to accept back some of that care, you know?"
Mhm.
And usually most people can understand that. It's like, "Oh, you've been taking care of everybody else. Now, it's the moms that have the hardest time accepting care back." But those are usually
Yeah.
lines that people are like, even if just for a moment, they're like, "Okay, this isn't so bad." But yeah, it's a huge issue.
Yeah.
People, I mean, I can't imagine being in that scenario where, like, my friend who I grew up with had some health issues all through our teen years. And I remember the first time she was in the hospital and she told me about how the nursing assistant was like a good looking male and he had to help her off the bedpan. And she's like a teenage girl. And it's like,
Mm-hmm.
"Hi, I'm maybe a little bit older than you and really attractive, and now I'm going to wipe your ass." So like we all have these experiences at some point in our lives where we're like, can I just vanish now into nothingness, cuz I'm
Yeah.
really fucking humiliated. And unfortunately, that's what medicine does for a lot of us. So
For sure. For sure. It's kind of like, after I had my kids, there's like absolutely no modesty anymore. Like
that's what
you
I
go
hear.
to the doctor. Yeah.
You're like, "Whatever."
You know, so when I had my son, he was preemie, he's 6 weeks. And some people get birth photography, which I would have loved to have a photographer in the room, and um, but the picture I would have loved the most was of the resident who was attempting to put an epidural on me. So I went from 4 centimeters to 10 centimeters in a half an hour. We weren't expecting that. Yeah. Yeah. And so and he's taking his sweet ass time because, he's just like junior resident, and the senior resident's talking to me about my herniation in my back. And I'm like, I already talked to the senior resident. Like, I want to talk to you. I'm trying to breathe through these contractions. And pretty soon I was like, that's it. Pull that needle out of my back. He's here. And my nurse is like, no, 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 let's breathe through. I was like, no, he's here. And from nursing school, I remember the ring of fire because my daughter, I had an epidural, so I didn't experience, and I was like, it's burning. He's here. Get that needle out of my back. And so he pulls the needle out of my back, out of my epidural space, because he was just trying to thread the catheter. I go on my back. Ash was already pretty much like crowned and like out. Like Nikki wasn't there. No one was there. My midwife, when she came in to deliver, she said the resident was in the corner, just like terrified. Because they're not usually in there during that. Yeah. And so she said his face was like like that, out of all the pictures I could have gotten, my son, being born, or me, I didn't really get to hold him because I was sick with RSV.
That like sharded his
I want the
resident's
face
in the corner. Oh, that memory is imprinted in that memory.
I know.
That's awesome. Oh my gosh.
Oh, yeah. Yeah. Oh.
That's an experience. Motherhood is wonderful. I'm glad that there are lots of you out there that want to continue the species, but I don't think I was ever built for that. Oof. Just listening to that story,
it's
I'm
work.
like, I would be, yeah, girl. Yeah, girl. No, not for me.
Well, I'm actually probably lucky that he was preemie, because he was still big. He was like still like 5 pounds, 10 ounces at 6 weeks early. Mm-hmm. Because now he has this giant head. Like we went back from one of his like newborn appointments, and the doc's like, he has microcephaly. And I was like, he's fine neurologically. His dad just has a giant head. So they had us measure it. Those paper tape measures. Yeah. And I brought it home and measured my husband's head, and it wasn't long enough. Like I had to add distance on it. So when I went back to the doctor and I was like, yeah, it wasn't long enough. They're like, ha ha ha. And I was like, no, really, it wasn't. And he came back, he's like, his head's like 6 standard deviations over normal. Like, so he's like, yeah, you're right. It just runs in that family. So I think I was probably lucky that he came early. Yeah.
Yeah, it sounds
Carolyn.
Like it. I can't imagine.
Yeah.
How big
was funny because in nursing school, I don't know. It was like 7 pounds, 10 ounces, something like that. Mm-hmm. But I had horrible back labor with her. It was funny because when I went in, and I had this in my head, like I didn't want to get enough. I went because I had that herniation from poor ergonomics when I first started nursing, and I didn't want an epidural. And so when I go in though, and they check me, and they're like, you're only 2 centimeters. The literal words that came out of my mouth was like, you've got to be fucking kidding me. This is 2 centimeters. As soon as I get to 4, you put that epidural on my back. Like, I can't do this shit. The nurse is so sweet. She's sitting there. She's trying to like breathe with me. She's like, and all I could think in my head was, fuck that. My patients have to hate me. Like, because I was working on burn, And so when we're in the tug room, we're doing these horrible things. I'm like, okay, let's breathe through the pain. Let's breathe through the pain. Like, she's having me breathe through the pain. I was like, oh my God, I'm not going to say that to a patient ever again. I am an asshole. Like, shut up.
I've thought about that before. Like there have been a couple times on rescue where I've wanted to say to my coworkers, like, dude, shut up. Like, do you realize, like, as they're wiping someone's like raw bleeding ass, they're like, it's okay. I'm like, no, it's not. Baby, it's not okay. Like, look at that.
That
like, there are other things you can say, but don't say it's okay. No.
Yeah. Yeah. No.
Yeah. So, that, I was almost 10 pounds when I was born.
It's like a random turnaround.
Yeah. Let's just say,
wow.
God bless my mother. Yeah. I was like 9 pounds, 10 ounces.
Yeah.
I was 2 weeks late. It was
I was 2 weeks late.
yeah, it was a situation. It was a situation. My mom is a tiny lady as well, so God bless her. Whew.
Yeah. Yeah, it's being a mom's hard. I just always laugh because in nursing school, they I don't know, did I say this already? I feel like I was going to, and then I get on a rabbit hole. In my maternity class, right? They said you develop amnesia about the pain of birth.
Mm-hmm. It's the same thing with
Yeah,
nursing school itself.
in nursing school, I believe, like, because I'll be, teaching my students, and like, I don't remember the stress, like being this stressed. And then like a time hop when I used to use it, our Facebook will come up. There's this one post I made when I was in nursing school that said, oh, I was in a research class. Oh, systematic reviews. Let me count the ways I love you by like plucking out each individual armpit hair and banging my head against a wall. Like, it was like a haiku of, like, I was like, oh, I was stressed. But labor.
If you ever want to know what nursing school was like for me, you'll have to go back and listen to my podcast episode on what it was like. It will make you sob for me. It was a story. It was the greatest story ever, greatest and worst nursing school story ever told. Like I've seriously gotten like letters from people that are like, wow,
Oh.
your story was so bad that it makes me feel like I can do this. Which is what I wanted. I wanted people to listen to that and be like, oh yeah, I'll get up tomorrow and do this all again. I can do this. But I also was a non-traditional student. I had like a lot of shit stacked against. Well, I know you were a non-traditional student as well. People can listen to our last episode and they can hear that whole story. But I feel like there was a lot of shit in my way. But I did it. I'm a testament that you can climb over all the bullshit. But there is a lot of bullshit. And then you get to go on and graduate and have a whole new set of bullshit to deal with. But I still
whole new set of bullshit.
Do you have any other pet peeves on your just top of mind on your list right here?
Oh, well, yeah, of course.
Keep going.
Well,
Keep
the other one
going.
I brought
Keep
up
going.
before, because it's a huge one. But putting non-sharps in the sharps container.
Oh yeah.
So
Like what? Like what do you mean for
it
those who
happens
may not
all
know?
the time. Because because of HIPAA, we're supposed to take off the stickers with patients' names, to protect patients' identities. Well, so nurses, instead of taking the sticker off, because you could easily take those stickers off and like fold the name in on itself, so it's like, I suppose if someone's really dedicated, they could like get through the trash and find stickers and unroll them, but I doubt it. So they just put the stickers, either like just the stickers into the sharps container, which makes them stick to the slide, like into the container, which either like everyone can see the name like plain as day and then you can't get it out, or sharps actually get stuck to it. Like there's like
So
a
when you
slew
go
of insulin syringes, stuck to the sticker.
Yeah.
Yeah. I hate it. I go into so many rooms and I like go to put my sharps away, and I have my sharps containers full. I looked the other day and there was like IV tubing and IV bags. I'm like, oh, someone's like, you gotta be fucking kidding. Yeah, like,
although
come
in my
on.
defense,
There's a trash can right next to the sharps container.
Yeah, there was once though that I was in a room and I went to pull some gloves out of the glove boxes directly above, and like a handful of gloves fell out of the box and fell into the sharps container, and I was powerless to do anything about getting them out. They like fell into the slot and fell into the sharps container. I felt really guilty about that, but that was like an isolated random incident.
Right.
Like we're talking about people shoving tons of shit in these sharps containers and then not taking the responsibility of changing them, which we all have the power to do.
Yes.
And anyone that I work with that is listening, if you want me to show you how to change the containers, I will happily show you how to change the containers.
No, see, I'm horrible at changing the containers. Like, I'm horrible at it.
Someday I'll show you.
Fantastic, because I'll sit there and I'll bitch like, son of a bitch, people just keep putting the shit, and then I like try to shove my
Oh yeah,
sharps in there.
no.
I'm like, I'm gonna just shove it in there.
No, that's the scary part. That's you got to get to them before they get so stuffed that you can't get your fucking lid closed.
Like one more sharps. I can fit one more sharps, and then I'll change it, and then I go back for the lunch insulin.
You're part of the
son
problem.
of a bitch. I haven't changed it.
Part of the problem. Knock it off.
Well, I suppose at that point I am.
Yeah. Oh, so now we have those like RX destroyer bottles that we destroy controlled substances in. I don't know. I'm sure other hospitals use similar stuff. They're like these bottles that like we open up and we shoot, like when we have to waste medications, which I wish we didn't have to waste so many medications. They have gotten better about giving us medications in smaller dose syringes so that we're not just like shooting huge syringes of stuff. But that RX waster, it smells like the like sulfur, whatever, egg nastiness. Egg sewer smell, and we're in an enclosed medication room, so it just constantly smells like sewer farts in there at all times. So now it's like when you want to waste, you have to like be poised and ready to like open the cap, squirt it in, close the cap. It's like I feel like a junior high kid that's like trying not to like let the ghosts out. Like it's so disgusting.
When we first switched to those, I had it smell, like I went into the med room and in the morning, I was like, what is that smell? Is someone fart in here? And I'll say, I'm guilty. Like I have passed gas in the med room before, which is probably another pet peeve of someone else's.
I'm going to add that to my list. When Mackenzie farts in the bedroom.
But I'm not the only one. But no, when I came out, like, no, I know. So when I came out, I was like, another nurse was going in. I think I was going in. And I was like, that wasn't me. Like, I don't know who farted in there, but that wasn't me. And then later on in the day, I went back and I was like, it still smells like shit in here. Does someone fart in here again? Like, what is the deal? And it's like another nurse, a different nurse came in. She's like, yeah, it does. And she's like, oh, it's the waster. Like
the bottle.
And I was like, okay, that makes sense. Yeah. Yeah. But I was worried people were going to accuse me of farting in the med room.
You're just crop dusting.
I was ready to accuse all my coworkers of doing this.
Yeah, like suddenly everybody's angry at each other and like accusing each other. Like, what'd you have for lunch? Like everybody's like hostile, turning on each other when really it's just the medication wasting solution. Yeah, that stuff is foul.
It is
horrible. Just think of the people that work in the plant that like processes those. Can you imagine?
No. No.
Yeah, no. Yeah, no. So yeah, that stuff is pretty foul. But I am glad that we have that and that we're not wasting that stuff in some kind of like irresponsible way. So it's good. It's good. It's
very true.
Just make sure you keep that lid closed. I went in there one day and the lid was just like open, like willy-nilly, flopping in the breeze. I was like, who? No. Unacceptable. That is like a crime against humanity in the med room. You don't get to, you can fart in the med room all you want, but you put that damn lid back on. Unacceptable.
For sure.
Unacceptable. My last pet peeve of the evening is when I go into the room and I log into the computer to go scan the meds and the fucking scanner is dead. Because we have like the little wireless scanners. And the scanner's dead. And then you got to stand there for fucking 5 minutes, small talking with your patient while you're waiting for the scan, because you don't want your percentage, your scanning rate to drop. But all the fucking time, somebody didn't put the scanner back in the right way, or they put it in backwards, or they put it in upside down because they weren't paying attention. And now you got to wait. Or like you scan their wrist bracelet, and then there wasn't enough juice for any more. So then it dies again. So then you got to put it back in the charger. wait for it to get just enough power to scan their meds. And if they have a lot of meds, or if you have to hang an IV med, then you got to put it back in the charger again to get enough juice to scan the IV med. And you're like, Lord, please, I just want to get out of this room before they have to shit or do something else that I don't want to have to do. And then you
Oh
put
my
that
goodness.
scanner in and you make sure it's in there good and tight.
Or it's like when the holder has like,
Oh yeah,
is it
it's like
holding it
loose.
right?
It's like loose
So
in the charger,
it's
so
like
it's not
loose.
connecting.
Yeah. So it's not connecting, and you're sitting there like, so it's lost its battery, and you're sitting there having to hold it at the right angle.
Oh yeah,
like
to
to
get
get
it to
it to charge. You know,
like safe
Yeah.
braking. And you're like,
Okay, I got a bar. Quick, you take it off. You scan one thing, you put it back. Oh my goodness! I always tell my students, so because that's a hard thing. Like my students always put it back incorrectly because you know they haven't used it.
because they're new to it. Yeah.
And I'm always like, but it's, you know, so which is legit. So I always point out, like, you need to make sure you have 2 lights on here, or else you're going to come back and you're going to be really pissed that your scanner is dead and you can't do anything. So like, just this is how you put it in. Like, make sure you have 2 lights.
And then when your scanner is so dead, it takes a long time, but you got to give this med like right now because your patient's in pain and they're freaking out. So then you got to go find a portable computer workstation on wheels. And then when you go find that, then that's dead. So then you got to bring that back to the room, plug that in, wait for that to charge and boot up. And then that's got the scanner that's on like the 1980s phone cord that only reaches like so far. So then you got to drag the computer. So it's stretching between like where it's plugged in and like where your patient is. So that, yeah, it just, those are the nights when you're like, son of a fucking bitch, why does nothing work around here? And it doesn't matter where you work because this shit happens everywhere. When shit is not charged, it is a problem. So that is my advice to all of you. When you are on your units, make sure stuff is plugged in. Suction canisters, IV pumps, because you never know when you're going to be the person that goes into the storage room to get something for a patient, and every single one in the fucking storage room is not working or dead or low battery, and you got to go to CT or X-ray or some shit like that. Don't do it to yourself and don't do it to your coworkers. Take an extra 5 fucking seconds and plug it in. That's my soap.
I want to know. I totally get that. And I want to actually ask your listeners if anyone else can relate to thermometers being an issue, because I have never had such a difficult time finding a freaking thermometer that works to take my temperature, like my patient's temperature. Like, what in the world? It is a hospital, and it is a big hospital. Why are there 3 thermometers for 26 patients? Like,
it's been a problem in every unit I've worked for the last, like, I've worked at this hospital since 2005. It is the greatest plague of the hospital. It is like there are gremlins in the walls that steal our thermometers. Even when we had thermometers that weighed 15 pounds apiece and you had to carry a separate box of thermometer probe covers, like even back then, it was like, where did they go? You need a fucking forklift to carry it. How did you lose that thing? Still.
I know. I don't know. It just drives me bonkers. I know some floors like tie them to their wall, like they have them on an anchor, you know, and they say like it's just long enough. My husband's a nurse at the VA, and he said like they put them in the stupidest spots, like you could barely reach the patient.
Or then when one breaks
or
something like that, then you can't, like when you go to send it to bio, you have to like cut the wire, and then you have this like jaggedy sharp wire hanging off the wall. By the way, I just had an electrifying experience. I pulled my throw blanket off my lap and the headphones in my ears crackled, and I thought for a second I was about to electrocute myself on video, but I'm alive still, so we're okay.
I'm very glad.
It was a weird electricity. It's dry. It was like pop rocks in my ears.
Oh, that would be weird. I didn't hear it.
No, I don't think it came through on the recording. I think it was just static electricity. It was just very strange.
Yeah.
Well, we have a lot of pet peeves.
Do you have the same thing with the locker room on the floor?
Yeah.
Oh my
Yeah,
God.
I
I
do.
could go on for hours
I
about
could
pet
go on for
peeves.
hours too, but
I
I
didn't even
think
actually realize, I start talking about it and then
yeah, no, it goes on and on forever. And the thing is that I've had people like write to me and be like, I was listening to your episode and I was like laugh because I've done other pet peeve episodes with other nurses and people have said like I was laugh crying by the end of your episode because like every single thing you talked about is stuff that like drives me crazy at work. So there really are these like universal truths. So I know that there are going to be people that are going to
for
message
sure.
me and be like, "Oh my God, that thing drives me fucking crazy." So there's more. There will be more. I think we will come back for more. I think that we should maybe in the future divide a couple up into like subcategories, like just like equipment or just like multidisciplinary shit. Because there's
Yeah.
so much. There's so
So
much.
many. Well, and then to you get me and I get a rabbit hole, like my ADD is like, oh, there's something shiny, like
But that's
I
what's the
just like,
best about it because I thought of some while we were talking that weren't originally on my Post-it note. But like it truly is that. It's like you think of one thing and then it reminds you of something else, and then you started talking and but that's how it happens at work too, where you're like bitching about one thing and then like 10 other things pop up in your memory. But that's how it works. I'm only even stopping because I'm getting tired and I need to refill my drink. But I've been awake since the wee hours in the morning, and
yes,
I'm
it's,
like,
oh
man, I'm
yeah,
getting tired. Um,
yeah,
but this was a really good episode, I think, and I
yeah.
really want to.
I
We have fun with this. I really want
have
to
fun
have
with
you
you.
back
Yeah,
sometime soon because I want to pick your brain about your role as a clinical instructor because I am, I have taken a few students now for senior preceptorship. I know other coworkers on my unit have students right now. I know that there are other people that have written to me that don't work at my hospital that want to take students. So I think that you have a lot of really valuable experience to share because of the students that I've talked to that have come through your class. They
yeah.
appear very well
You're one of your
prepared.
students is,
Yeah. And she's well prepared. And
yeah.
she said that you have certain things that you have done that have created this preparedness. We got
There's
to talk
always
about that stuff.
still even, yeah, yeah. Oh, I would love to. I enjoy teaching and I enjoyed precepting. I think that's something too. Like when you're precepting new orientees too, you're basically teaching still, right?
Yeah.
So even when they've finished the NCLEX, so you don't have to just take a student to benefit from it, but
Yeah.
you're taking any kind of like new people.
And it's interesting because even though I feel like I have a natural ability to teach, obviously I haven't been taught how to teach. And so the things that I don't know how to teach or the situations that I don't know how to handle as well, I don't how do I want to say this? I don't know those situations until I'm in them. And then I'm like, oh, I've never had to handle this before. Um, and so it's an interesting learning experience and it's humbling because even though I know I'm not a professional teacher and I know I'm a novice, it's interesting when I have those moments where I'm like, oh, I did a good job teaching that. And then there are these other moments where I'm like, whoa, I could really use some guidance on how to be more effective in this role in the future. So I'm going to pick your brain.
Awesome. I think teaching has made me a better nurse for sure. I learned just as much from my students as they from me.
And it makes me aware of where my gaps are. Because like the other day, she was like, somebody was like, hey, do you want to give blood with your student? And I was like, ooh, that's a skill I'm not really comfortable with because I don't do it very often. So that was just like a highlight of like, hey, you should probably be more comfortable with this skill.
But you know what the beauty is that, and I always tell my students this too, and when we talk about it, I'll probably repeat all this anyway. If you think you know everything, you're unsafe.
Yeah, for sure.
Right? I still, when I give blood, I have to look up the protocol too, because I don't do it enough. There's still things that I'll come in and I'm like, I haven't done that before. And I'll have to have, the like another nurse show me, because it's been a while since I've, because I'm not on the floor tons.
Yeah.
And it's good for new nurses, and it's good for students to see that though, right? Because so many times they come out and they think they have to know everything, and that they don't, and it's not the case. Like, you never have to, like, you're never alone. Yeah. And if you are, find a new unit, because, like, because you just, so that's, students ask really good questions, and I'm like, you know what? I don't know the answer to that, but let's look it up together, So it's a beautiful thing to show them, show someone learning that you can say, you know what? I don't have the answer to that. Let's see if we can figure it out.
Ooh, I look forward to doing this again soon. This will be a good episode. Awesome. Yeah. Okay. Well, let's hold that thought right there, because we don't want to spill any more of the beans yet. They got to come back for that. All right. Well,
I've got so many beans.
We got so many beans, Mackenzie. I look forward to seeing you again up on the unit, but until then, we'll just have to put a pin in it. And until next time, happy nursing, Mackenzie.
Yes, happy nursing, Adrianne.
Thank you.